Well, let's talk about then physiotherapy management of obstetric anal sphincter injury. This is what our UK guidelines suggest, that all women should be offered with physiotherapy for 6 to 12 weeks following primary repair. However, when you actually look at the literature, there is hardly any evidence about the specific interventions for this group of women. So with that in mind, the aim of this presentation is to review the most up-to-date physical interventions that you can do with these women and hopefully apply them to this specific group. I'm also going to review 4 articles. They're quite interesting from the physiotherapy point of view. Obviously, I'm going to go from the acute management, and there's not that many of us here, and then there's a few physios, so yes, this makes sense to all of us. But in many countries, physiotherapy is not available straight after giving birth. So some of this information obviously could be given by the clinical nurses, the midwives, or obviously the doctors reviewing these patients on the wards. I'm also going to go very quickly through physiotherapy assessment, just so you can actually see what is our clinical reasoning and determining what is the best treatment. And then I'm going to review the physiotherapy intervention and those articles regarding the management of these women. So just to give in mind that the aims of physiotherapy, or the aims of conservative management in fecal incontinence, is to obviously strengthen the pelvic floor, including the external anal sphincter to increase the sensibility of the rectum, to keep the rectum empty, and to change stool consistency. And it's a mixture of those 4 interventions that will keep our patients continent and will help them with their quality of life. Now, we obviously are talking about fecal incontinence, but as Heidi said before, and Alexis, some of those women will also go into rectal evacuation difficulties. So it's important that we identify that during the assessment. Now, the management of evacuation difficulties obviously goes to correct that muscle discoordination. An example will probably be, those women that might end up having an anal fissure following primary repair. They actually are afraid of evacuating, and then they might actually present with an aneurysmic component, for example. To correct defecation patterns, to strengthen pelvic floor, because I'm sure you know that when you actually strain for a period of time, you can actually affect the pudendal nerve, and again to change stool consistency. And again, that mixture of those 4 interventions we know will help our patients to evacuate a bit better. So why do I call acute physiotherapy management? Acute physiotherapy management, or acute management, is for those women that actually are on the ward. In our hospital is routine clinical practice that we review them, and this is the information that we give them. But please bear in mind and say that if that's not available in your local hospitals, that anyone else can give them this advice. I always say to patients that I don't see the injury to the sphincters any difference that if someone came to A&E with an ankle sprain. They follow the same principles. Think about the inflammation process and recovery and remodeling. Okay, so they need to rest, and ideally, for the little literature that is available, they need to rest for 24 hours before they start to do any gentle pelvic floor exercises. That they should be given advice on how to use ice therapy, and ideally they should be using it for 24 to 48 hours following the primary repair. And compression and elevation means that they should actually rest in a position that are actually not compromising the perineum. That is, that sometimes lying on your side with a pillow in between the legs, that is with pillows underneath the ischial tuberosities, so you're taking the pressure of the perineum. So there's specific cushions available. I'm sure you've seen them. However, I think they're quite expensive, and 2 towels are actually as equally effective. I haven't studied that, but I don't think there is a point of spending money on those cushions anyway. Then when we also see them, we give them advice, on how to actually empty the bowels. And remember what Heidi and Alexis said before, it's very difficult sometimes to empty your bowels. And I'm sure when you ask those patients, they are all afraid. In their mind, they think that if they open their bowels, somehow the stitches will be undone. So sometimes they try not to go. But obviously it is important from their recovery that they do it. Now, in our hospital, what we say to them is that they obviously need to have a good defecation technique, but also simple things like, can you protect your perineum when you're doing it? You know, with a toilet paper or a pad, or just the hand over the perineum will be enough to give them the confidence to empty with no problems. And then pelvic floor muscle exercises. Yes, we know it's effective in in fecal incontinence. As to what to do straight after giving birth, we don't know it. And I always say to patients, you must start doing pelvic floor exercises, very gentle, always with no pain, okay, and then progress from that, okay. And what I say to patients is that, and think about that sort of soft tissue injury, think about an ankle sprain, that we always say to patients, you need to start moving your your ankle, because as you move it, you are improving circulation, and therefore you are speeding up the healing process. So with those women, it's exactly the same. They need to be able to do those exercises very gentle and progress from that, and that's what it should be given to them. And we do it partly because I'm a little bit obsessed about Oasis, but anyone within the team, that means the medical team and the midwifery team, should be able to also raise what will happen after primary repair once they come back to clinic. So things like you might actually find it difficult to control wean, you might have to run, you might have a few accidents, and actually that could take up to 12 weeks to recover, and there's nothing to worry. It's something that will get better or not, and if it's not, you can always contact us. Obviously, within our protocol, we see women, the medical team see them at 6 weeks, and then they come to our clinic at 12 weeks. But on discharge, they are given our number, so if they have any problems, they can call us, and then we can decide if they need to see us, or also they need to see any of the specialists. I think there is a very negative information for these women, and they all get really scared. And I think normalizing the symptoms, what to expect, and the time recovery is very important. So I'm going to skip very quickly for this, but see for example that we had someone refer from the third degree tear clinic, or someone refer 10 years down the line. When they come to see us, obviously we need to do a bit of history, and that history will obviously involve bladder, bowel, sexual, vaginal symptoms, obstetric history, gynecological history, diet and fluid intake, psychosocial history. This is important up to the first year from giving birth. How are they coping? How did they feel after giving birth? What is their main symptom? Obviously, because their main symptoms is different to have fecal urgency than to have passive or post-defecation soiling, obviously. We know that patients are getting better in an objective measure because we obviously use standardized questionnaires. In our unit, we use some Marks continence score, which has actually been previously investigated with Oasis. It's quite simple, and that's what we use all the time. But you could actually use Wexner score, or the GPE. But it's also important when looking at bowels to get a defecation diary. That means that for a week, I want you to write down really what sort of poo do you do, do you have urgency, how long can you actually delay, and so on. And Thompson score is for bowel evacuation difficulties. Very quickly, I'm sure you all do this, but obviously when they come to clinic and we see them, you need to properly assess these ladies. And, you might actually be able to do vaginal and anal examination. Obviously, sometimes that might be too much on the first appointment. And then, obviously, if they have bowel symptoms, we will go down the anal examination first and then go and examine vaginal in a second appointment. But, relevant to this group of women is, okay, how is the anus? Is it a patulous anal canal? Can you actually see the reflexes? Can they contract? How long is the perineal length? Can you see any sort of prolapse when they cough? Exactly. Can you see a small rectocele? What are you actually seeing in general? Are they atrophic, especially if the first year up to, the first year following repair, they're breastfeeding? Can we see a bit of atrophy? That might actually give some symptoms of dyspareunia as well, on top of that, the bowel symptoms. So just look at those and everything, really. And then obviously from our physio point of view, or, we in the unit, we also work very closely with our clinical specialist nurses, so we all do the same. So, and this is very important that, if you don't have a physio, then of course you're going to have a clinical nurse specialist that can actually do the same. But, it's very important that you assess the pelvic floor, either vagina or by a rectum. And the reason for that is because you already know that 50% of women will do the exercises in the wrong way, just by verbal instruction. Either they will do an inefficient pelvic floor contraction, or, which is worse, they will actually do a Valsalva technique. Therefore, that will not help them, okay? In terms of documenting what we see on the pelvic floor, obviously the ICS recommends that when we are grading muscle that we use absent, weak, normal, and strong. And I'm not sure if you're aware that back in 2009, this sort of, this one came along, the pelvic floor muscle function assessment scheme, which is actually great in a way that you're looking at pelvic floor, but you're also looking at, can you find any asymmetries? Can you find pain? Is there a difference between front and back, right to left? Is the person overusing their concomitant muscles, as in, if they're doing a pelvic floor contraction, are they using their abdominals, their adductors, their glutes? What is there they doing? And actually that is really important because, as Heidi said, there is a decreased sensation. So if you don't have a proper sensation around the area, you're more likely to use whatever is around to compensate for the lack of pelvic floor strength. So that's actually very important. In the UK, we use the modified Oxford scale on a scale from 0 to 5. 0 is no muscle pelvic floor activity, and 5 is a really strong. I have to say that I haven't seen that many 5s in my career. Okay, but this is really important when actually determining what is the best treatment for them. And the reason that I say that is because there is a few studies that have actually, for example, give electrical stimulation to patients that that they didn't stipulate it, that have a voluntary pelvic floor contraction. Yeah, I'll explain you later on about that. And how we actually go around giving them their specific pelvic floor regime is we use what we call the Perfect scheme. P stands for power. So on a modified Oxford scale, from 0 to 5, what is your strength? Endurance refers to how many seconds, if you're squeezing and contracting, how many seconds can you do before you fatigue, and how many of those repetitions can you do in one go. Whereas fast refers to how many fast pelvic floor contractions you can do in one go. And ECT refers to every contraction time. So can you actually see an automatic response of the pelvic floor when coughing? Can the patients hold the pelvic floor and cough at the same time? Can you see any sort of concomitant muscle activity? And this Perfect scheme is what actually will tell us what to do with the patients. In some occasions, obviously, we cannot assess patients, let it be they're menstruating, or they are very early in the postpartum period, or they have a vaginal infection, or they don't want to be assessed because they have been through so much through the delivery that someone else in that vagina freaks them out. So, but we need to have an idea if those patients, at least they are contracting the pelvic floor. And then in our physio department and in the pelvic floor unit where I work, we do have the real-time ultrasound, and it's actually quite a good tool in a way that, as you can see, you can see here the blood, where the ultrasound is just above the symphysis pubis joint, and then you have your bladder and the bladder neck, and so there we go. That's the bladder neck. So if you ask them to squeeze a pelvic floor, you can actually see the elevation of the bladder neck, and so you won't be able to test for asymmetry or tone or pain or any scar tissues, but at least you can, say yes, you are actually squeezing those pelvic floor muscles in the wrong way, and you can actually, sometimes we actually use it as a objective measurement as well, especially during the pregnancy. Whereas if you actually did the exercises in the wrong way, look at that descent. Okay, and that's what we need to avoid, because remember that descent will compromise that pelvic floor muscle function even further. So a good technique, and also especially for those women that, so if we have actually done internal examination, and we found that overusing their abdominal muscles or their adductor muscles, or they're holding the breath, this is actually a very good feedback technique to just allow them to control that breathing when they are contracting the pelvic floor muscle. So I'm a big fan of this, as you can see. I'm going to show you what a pelvic floor contraction looks like. Just, I think it's very relevant to what we're doing. So if you look at the picture, yeah, and you can then see how the external anal sphincter actually works with puborectalis. Did you see it? And so that is the importance that when they're doing the pelvic floor exercises, they actually start with the external anal sphincter. And I always say, I really want you to have a look at the position of those pelvic floor muscles. Think about that 45-degree angle of... sorry, just have a look. Yeah, look at that 45-degree angle. Yes, and that, how this is a natural position of those muscles. You know, the importance of what Alexis was saying before about the anorectal angle. And you know, when you're actually doing a pelvic floor contraction, I always say to patients, you need to imagine that you're trying to not only squeeze but elevate those muscles within the pelvis, and that is what actually will help from the continence point of view. Now, very quickly, we're quite lucky, I think, in the UK that sometimes patients will come to us, but also because we have a very good relationship with our consultants. So it means that if following or failing conservative management, these ladies didn't get better and hadn't actually been through our system, we could actually order those tests. You know, just to find out exactly what's going on. I'm referring to the patients that might have a third-degree tear in another hospital, and then they come to see us and they didn't have any sort of test. Then if following 6 to 9 months of conservative management didn't get better, then we can go ahead and order all those tests. Obviously, you know, sigmoidoscopy and colonoscopy refers more to red flags and so on. But, you know, that's something that we can do as well after failing conservative management. Now, when we actually look at the interventions that we do, so I couldn't resist to put this slide up, because we always talk about Dr. Kegel, about the first one that introduced pelvic floor muscle training, which he was the first one to actually evaluate what we did with this woman. But actually, it was Margaret Morris, a physiotherapist from St. Thomas, the first one that actually said to this women back in 1936, you need to start squeezing to prevent and treat urinary and fecal incontinence. Needlessly to say that sometimes I trick patients under that story to make them feel a bit guilty and to engage them into exercise. But, you know, what do we know about pelvic floor muscle training? Needlessly to say, we know that it works in urinary incontinence, it's first-line management. We know now that it also improves pelvic organ prolapse. And we also know that improves fecal incontinence. The results are not as good as urinary incontinence, but I think it's because the studies have about the intervention for those patients they need a bit of work. You know, when you actually look at all the studies, they have to use different dosages of exercises at different time scales. So, you know, I think, you know, in the future we will see that, you know, especially with the fecal incontinence, it will improve. At the moment, it's at 50% improvement. And this is something that I'm very passionate about it, because, you know, everyone is very quick to say, oh yes, I done my pelvic floor exercises and it didn't work. And when I say to patients, you know, but what did you do? Okay, because what we know is that giving a leaflet, it doesn't help. You know, that's the reason to examine them. All right. But also, you know, it is important that, you know, when you are actually prescribing exercises to these women, and this is what the American College of Sports Medicine dictate, is that when you're giving exercise, you need to follow those 4 principles. And that is actually very important. So specificity refers to if you're doing pelvic floor exercises, you start working on your pelvic floor. Now, some of my colleagues from the musculoskeletal department, they come to me talking about, or I have given them abdominal exercises. And I was like, yeah, that's good effort, but I don't think that will help the pelvic floor, So we need to be specific about the pelvic floor. If later on you want to enjoy, you want to join their abdominal muscles because they also have a weakness, then it's fair enough. But to start with, they need to start contracting the pelvic floor. Overload. That means that, they need to increase the number of repetitions, they need to increase the number of holding time. And I always say to patients, you don't run a marathon in one go. You start practicing. You might start doing 5 minutes, then you do 10 minutes. So with pelvic floor, it's exactly the same. And unless you try to increase the number of reps and holding time, muscles will not change. Remember that muscles need to be challenged in order to change, okay? And then progression, okay, so you might not have your sensation, so you might start doing the exercises lying down, but as soon as you get better with that sensation, then you move into sitting, then into standing, then into moving. Remember that the pelvic floor muscle, including the external anal sphincter, is a dynamic structure, and together with the diaphragm is the only group of muscles working against gravity all the time. So therefore, if we're actually working towards that automatic, or to recover that automatic response, that's what we should be aiming. This is the other thing about the studies on OASIS, ladies, that to actually change muscle, you need a bare minimum of 5 months. All of the studies done with these ladies are between 8 weeks and 12 weeks, which we know that that's not enough to create hypertrophy that will actually change the squeeze pressure, okay? So it should be for a bare minimum. We actually normally go in our unit for at least 6 to 9 months to ensure that the muscles have actually changed. And then what happens with those ladies, or with anyone, especially if you have had a baby, and you ask them, have you done your exercises? 90% of women say, no, I haven't. This is the major problem that we have. The exercises are kind of easiest to do, but it's complying to that exercise regime. So how do we go about that? So obviously regular sessions, with the therapist. Nowadays we have an array of iPhone apps that reminds women about the exercises. Group sessions, something that will actually keep them going. Having a specific goals, that is really important. And then very relevant, to those women is the endurance of a squeeze. Remember that the majority of these women will actually complain of fecal urgency and flatus incontinence and fecal urge incontinence. So that squeeze, as Alexis was saying, you need to have a control. Sorry, it was Heidi. That you need to have that sort of control there to help you to get to the loo on time. So, if you actually have very poor function and you can only hold for 5 seconds, then you might not make it to the loo. And that is the importance of holding on for as long as you can. I talk too much. So actually, this is similar to the slides that Alexis showed us before. You can actually see here a good rest in a sphincter tone, and this is, an excellent squeeze pressure. Okay. Now, I want you to have a look at the next one. This is someone following obstetric anal sphincter injury. Okay, reasonable resting tone, but look at the squeeze pressure. Look at this, it's hardly non-existent. If you have this, you will not make it to the, to the loo. And, you can actually see the before and after. This is after conservative management. This was after 6 months. Okay, so you can actually see before. Yeah, look at the red, hardly non-existent, and after. Okay, and obviously that that refers us to how much of the sphincter injury, the repair. Obviously there is a few things that will actually change those pressures, but it can be changed. But remember that it has to be specific enough. Now, when we come back to adherence to treatment, then we obviously we use the EMG biofeedback. From the urinary point of view, like back in 2011, they already showed that actually women that have EMG biofeedback, are actually, they get better results, for the urinary incontinence. We don't have anything similar for fecal incontinence. But nevertheless, that there are some patients that need a specific tools or, objectives, and they like to see that the exercises they're doing is making a difference. So this is what the EMG comes in. Just for the ones that you know what EMG biofeedback is, it's basically a machine where women can actually use either a vaginal or anal probe, and basically registers the electrical activity of the pelvic floor muscles. Up to the day of today, unless someone has anything else to say, there is no information as to what is a normal parameter when we use an EMG. That is that the EMG that we use here in Brazil or in the UK or in Norway is absolutely different. But there is a few studies that shows that postpartum women are around 20 to 30. And what I say to women is that you need to at least double up that number to sort of show that you have changed your muscles. But, hold of that information. There is nothing on the evidence, on the literature about that. And then this is really, really important in those women with fecal urgency, and that is sensory training. Obviously we use either anal manometry or rectal balloon, and this is relevant for those women that have that urgency. Basically what we do, and I brought the catheters if you want to see it later on. Basically it's a balloon, and what we do is that we inflate the balloon very slowly until they have the urge to go, and then we ask them then to squeeze the pelvic floor. Also for those women that have that hypersensitivity, remember that if you are afraid that you're going to have an accident, then you're more likely to be hypervigilant about what you have on the rectum, and therefore they become hypersensitive. For training to tolerate larger volumes of a stool is really important. Lastly, I don't use that very often because this is more of functional constipation, evacuation difficulties for long-standing, not to these women. I haven't seen many women with this, but for those women that have hyposensitivity within the rectum, with the rectal balloon, we also teach them how to discriminate smaller rectal volumes. As I said, I have the balloon, so I'm happy to have a go later on for all of you. Now, very quickly, have 1 minute left. Now, electrical stimulation. Now, this is a personal opinion, but so far this year, I haven't given electrical stimulation to any of my patients. Okay, and from the literature, it's very clear that electrical stimulation is only given to those women that have 0 to 1 on the Oxford scale. That is that they find it very difficult to contract the muscles. If you have voluntary contraction, then you should work with that. Okay, the patients should also join the machine. That myth that you actually use electrical stimulation for 12 weeks and then you have gold pelvic floor after that is not real. And also, I must say that you have to be very careful, for 12 weeks after giving birth at least. Remember what Heidi said, those women do have a decreased sensation, okay, because they might have a pudendal neuropraxia, and then according to Abdul Sultan, that neuropraxia also takes between 12 weeks to 6 months to recover. So actually using electrical stimulation might not be very appropriate. The NAC, this is something that obviously we use with women with urinary incontinence. There's no studies yet that I might be aware with flatus incontinence or fecal incontinence. It was used in the studies by Hagen et al. And the Poppy study and Breakin et al. I have to say that anecdotally, we normally ask our ladies to actually use the NAC with flatus incontinence, and some of them, find it very effective. There is a study there to be done, by the way. So anecdotally, I can tell you that it can help them to give them that control. Now, I have 4 studies here that I'm going to go very quickly, but what I want you to think, you have it on in the handout, but these 4 studies, in principle, they are quite good because they actually investigated, pelvic floor muscle training and so on with these women. But for example, from my physio point of view, in these 4 studies there is no indication as to how they assess the pelvic floor muscles. And actually, in this one in particular, for example, they actually measure vaginal manometry with anal EMG. So 2 different complete interventions in 2 different approaches. So how do you actually say that, the EMG is better? I'm not sure how you get away with that. Of course, you're going to have a better result. You're having an increased sensation. So, good, but not that good. Anyway, so you hear that from me. And then later on, this is the same group. They actually now decided to do different interventions, the same route. No difference between, improvement of a squeeze pressure and so on. But again, 12 weeks of intervention, very early in the postpartum period. Again, didn't mention those patients could actually activate, because if you can activate, then obviously electrical stimulation is not going to make a difference. Then this study, I'll just mention it because it's specific to this group of women, but it's 8 weeks of therapy. That means nothing to us. Remember that sort of 16 weeks marks to change pelvic floor strength. And then more recently, we have had this one. Again, I'm not sure, randomized control trial comparing early home biofeedback physiotherapy with pelvic floor exercises. Now, early home biofeedback physiotherapy refer to a manometry, anal manometry, straight after giving birth. And the technique was used by the consultant obstetrician and the clinical nurse specialist. Now, the pelvic floor exercises were delivered by the physiotherapy and the midwives on the ward. And so, remember what I said about verbal instruction? We don't know if they're doing. And so this group actually make a really statement saying that early physiotherapy, didn't make a difference, but actually, they should actually look at the intervention at the time frame they actually use this intervention. So again, the good ideas, but actually maybe too early in the recovery process. They actually reported of adherence. Of course, if you're just giving birth and you have a primary repair, would you like to put an anal probe yourself? I don't think so, So, in fact, I'm surprised they didn't have more dropouts on the study. But never mind. So, once we go through, sort of pelvic floor muscle training, EMG, biofeedback, rectal sensation, what other interventions can we use that are part of this conservative management that can actually improve the quality of life of these women? The rectal irrigation, we're quite a big fan in our unit, and that's because actually there's no need to explain. You can actually see the before and after. And so for those women that have that sort of postification soiling because the sphincter is not very good, or that passive soiling, the rectal irrigation, and this is the two methods that we use in our unit. This is the Aquaphora, which I also brought, so I can show it to you, or the Peristeen. For those women, for our ACEs women, I feel that the Aquaphora is even better. It's very easy to use compared to the Peristeen, which got a balloon, and it might take more time, and especially if you have a new baby and a toddler, you need to do something that does the job quick. Loperamide as well. We work obviously very close with our medical team, and very slow doses of loperamide can actually help those women to get along with their lives. I always say to women, if you were in the beach, if you have to hold onto your hand water, sand, or stone, the easiest one to hold will be a stone. Therefore, actually modifying, that stool, provided you haven't actually do it with fluid or fiber, liquid loperamide in very small doses can actually make sure that you have a adequate stool consistency, which will make it easier to control symptoms. I'm already 5 minutes late. You're not saying anything, you two. And obviously anal plugs. Again, this could be quite useful. I see anal plugs as something more that we will see when those women come back 30 years down the line, okay? Because, anal plugs is one of those interventions that if you have a bit of a squeeze and resting pressure, they're actually quite uncomfortable. However, for those OASIS women that might return, by the colorectal surgeons, with sphincter defects, and passive soiling, it's actually a good management strategy. Defecation dynamics, very quickly, I think sometimes they, at least my colleagues in the physio, they always laugh because we're always obsessed about how to sit down on the loo, to the point that I put some posters on the toilet. But, remember that if you're not emptying properly, you're more at risk, of having fecal incontinence episodes. So actually teaching the patients to empty it adequately is actually very important, and especially as well for those women with evacuation difficulties. And then this is in general, this actually comes from these really good guidelines, from the Netherlands. I will encourage you to read them because it's got all of the evidence behind it. And they have exactly the same for stress urinary incontinence. But patient education and advice, and for these women, is remember, making sure that they understand what OASIS means to them. Do we need to actually supplement that with fluid and fiber? Review of the medication they're taking, and this slide is probably more, for those women that actually come back 30 years down the line. But then, obviously we also need to think about, can we do anything that could help these women? And actually, pelvic floor muscle training, those women that at 32, 38 weeks, have anal incontinence, were more likely to have fecal incontinence afterwards. So going back to what Heidi was saying, all right? So maybe we should encourage more women to do pelvic floor muscle training. And then perineal massage, obviously we know that if you do perineal massage, you're less likely to tear. So maybe we should be a little bit more adamant of encouraging women to do it. We have this conversation, Jane and I, before about the Epino. Is everyone aware of the Epino? Epino is a really interesting gadget that you put in the vagina. It stretches your perineum. But obviously the research about Epino comes from Epino. So we need to be very careful when we suggest women to use it. I always say to patients, your finger is far more important. But, is it something that we actually need to encourage women to do it as well? Concentrate on the, on prenatal interventions. And so in my conclusion, physiotherapy conservative management should be the first line, not only early in the postpartum period, but even if they come 10 years down the line or 30 years down the line. And I'm very adamant about this natural resolution of symptoms that does happen, before you start with any more aggressive interventions like vaginal, anal probes, and so on. Prevention is better than cure. The question raises about, do we need to inform more women about pelvic floor muscle training and perineal massage? And I always say it's really important that you have a good, as a physiotherapist, that you have a good urogynecologist and colorectal surgeon and urologist by your side. Okay, thank you very much.